what you're doing with delivering nutrition is you need to prevent complications from malnutrition. And so often, because I live in a large urban area that with a lot of homeless patients in our country, some patients will come in already malnourished, and then they have the burn injury, which also contributes to their nutritional needs. So estimating and supporting patients' metabolic demands with nutrition is extremely important in burn care. And if you don't have good nutrition, you end up with higher risk for infection and other sorts of multi-organ dysfunction, as well as long-term disability from muscle wasting and other things. A little case history. This is a 36-year-old paraplegic man who set himself on fire. He had full thickness injuries of his posterior leg. So this was an early patient that I operated on. I excised and grafted his posterior legs. But 10 days after I did the surgery, the patient decided he didn't want to eat anymore. And so I failed to diagnose the psychiatric component of this patient's care and his ability to tolerate what we wanted to do. So when he went on a hunger strike, essentially all of his grafts failed. So I needed to start him on psychiatric medication. Once we had really done that, I was able to optimize his caloric delivery via a PEG tube. And then once we got his wounds under control, he basically went on to heal pretty much all the skin grafts that I had placed before, came back and healed. But it was important that I got his nutrition under control first. Other things you can do to mediate the hypermetabolic responses in patients who are tachycardic. You can reduce their resting heart rate with propranolol, a beta blocker. Maintaining normoglycemia, not hypoglycemia, but normoglycemia is important. And we used to use a testosterone analog, oxandrolone, but that's no longer available in our country due to FDA issues with liver failure. So now important for plastic surgeons, and why a lot of you all are need to know about burn injury, is because you'll be asked to heal these patients' wound, or at least assist their bodies while their wounds are healing. And as you know, the skin has two layers: the barrier layer, the epidermis, and then the mechanical layer, the dermis. And you need to make sure that both are healed as the patient goes on to heal, so they can have best functional recovery. If you don't have a barrier, of course, you have lots of fluid losses and water losses. If you, as well as infectious risk, but without the dermal component, you end up with contractures and poor function. So knowing basics of wound healing, superficial injuries such as superficial partial thickness burn injuries will heal on their own by upward migration of the keratinocytes along hair follicles, as long as the wound is supported optimally and the patient is supported optimally. In terms of how we take care of those wounds, it's just a topical antimicrobial dressing and good nutritional support. My preferred dressings are antimicrobial silver dressings, such as silver sulfadiazine, or one of these advanced dressings called Mepilex AG, which is a sustained release silver dressing. Alternatively, you can use mupirocin or polysporin or any sort of other antimicrobial. And then one thing we may want to talk about is just strategies for topical antimicrobial use that would be best for you and your countries. Acetic acid, namely vinegar, would be a good low-cost one. Also, honey is something that could be used. Deeper burn injuries, however, may require more resources in order to heal those burn injuries, which could include surgery if the burn is deep enough or extensive enough. And in general, the surgical reconstruction of burn injuries is straightforward. It starts with controlling the wound by removing the burn tissue. More often than not, we do that with tangential excision, meaning that you take a sharp instrument and you remove layer by layer the burn injury until you've reached a healthy base. And then that's followed by split thickness skin grafting. Alternatively, because we're plastic surgeons, we have other more sophisticated ways of taking care of those burns, like using flaps and other types of options on the reconstructive ladder. So preventing infection is extremely important. That means maintaining a moist wound healing environment and applying topical antimicrobials. I've already touched on some of those, namely silver agents, so silver sulfadiazine, silvadine, sulfamyline, bacitracin, Bactroban, you name it. There's a lot of different topical antimicrobials. Really, you want to make sure you choose one that's effective versus Pseudomonas, because that's a common pathogen in burn wounds, as well as ones that's effective versus gram-positives like strep and staph, because those are the most common skin flora. Silver is an effective antimicrobial. It is effective versus antibiotic-resistant Pseudomonas, MRSA, fungus, and other types of microorganism. But there's any number of choices you could use. Chemical burns, different than thermal burn injuries. It's requires irrigation with continuous tap water for more than 30 minutes. That's you really don't want to neutralize acids with bases or bases with acids, and the reason you don't want to do that is you could create a exothermic reaction, back to our chemistry classes, which would add an additional thermal component to the burn injury on top of the chemical injury. Lipophilic substance like mineral oil is useful for removing tar if you have a tar burn injury specifically. Electrical burn injury, you need to distinguish between a high voltage or a low voltage injury, with a high voltage injury greater than 1,000 volts. And essentially you need to determine whether this is in fact a conductive injury where the electricity passes through the body, or whether it's just the arc flash from the electricity leaping from one component to another component and creating an explosion. The reason why it's important is that if you have a true conductive injury, you need to assess for damage to any of the structures that pass between the points of conduction. And for example, this person with foot burn injuries, or a patient with a mouth and foot burn injuries, well, if it goes in the mouth and it comes out the feet, then it's passed through the heart, the lungs, the digestive system, and all of the structures in between your mouth and your lung, or your mouth and your toes, including all the muscular compartments there. So you may end up with deeper structural damage secondary to the electrical burn injury, which may require monitoring or intervention. So I mentioned before the surgical treatment of burns, which is excision and skin grafting, and this is when you don't think that the burn injury will heal in a sufficient amount of time, which is to say somewhere between 2 to 3 weeks after the burn injury. Any patient that has a full thickness burn injury that comes into our burn unit, the first thing I'm thinking is, when can I take this person for surgery for removal of their burn injury and surgical closure? Understanding that full thickness burns, third degree burns, are not going to heal by reepithelialization and more often need surgery. And so in a bigger burn injury, that means decreasing the dead tissue load as soon as possible. So anybody with a greater than 20% full thickness injury, I try to get them into the operating room, ideally within 3 days, which is going to remove that big inflammatory burden from them and hopefully kickstart the healing process. It doesn't mean that I need to do the skin grafting surgery immediately, but at least I need to get the large full thickness burn off. Now, for extensive burn injuries that are very deep, you can consider a fascial excision, which means removing the burn and the fat all the way to the level of the fascia. That's a little bit more reliable in terms of preventing blood loss, and it's a quicker operation than doing a tangential excision, but it also leads to more functional outcomes because you're now removing all the fat, and so you don't have that layer of necessary tissue to help with moving, and you often end up with significant contractures if you're doing a prefascial excision. Now, we use a dermatome here to harvest a skin graft, which is a air-powered device, and it harvests at a fixed depth. There's many other ways to harvest skin grafts, which using a Humvee knife or a Watson knife, and I've used those before in a more austere environment, but the dermatome is the standard of care. Once you harvest your graft, it's important that then you can either mesh it or not mesh it, meaning that the meshed grafts you can see in the arm and the forearm here, and the sheet grafts on the hand. The sheet grafts will contract less and give you a better aesthetic appearance, but the mesh grafts can use less donor site. Really don't use full thickness grafts that much. Here's the appearance of a mesh graft before we put it on. And essentially the way it works is you put the skin graft on the underlying wound bed. You have blood vessel, the underlying wound bed, which is this part, has to be very vascular and has to be supportive of the skin graft, meaning that there can't be dead or infected tissue there. You end up with blood vessels growing into the skin graft, and then ultimately the skin graft is revascularized. There's any number of skin substitutes, cadaver skin, Integra, Alloderm, and more recently there's something called BTM, which is a polyurethane foam. These are all often used for basically staging patients until you get to the point where you can do a skin grafting surgery, but often they will need their own autologous skin grafts in order to have wound closure. So far, there's no off-the-shelf product that will close wounds without moving to autografting. Here's an example of a skin substitute in action. So this is a full thickness burn of the foot. You can see there's exposed vital structures like tendons here. This was using a skin substitute called Integra. You can see the tendons underneath there, and eventually this revascularized and allowed us to close this with a skin graft, as opposed to having to use a flap, which was helpful for ongoing functional mobility, given that there were exposed extensor tendons. So a lot of burns can be smaller and more superficial, and for patients who have good resources and can come back and see you in the hospital or the burn unit. So in the clinic, you'd want to just debride the burn wound with clean tap water and soap, and then apply an antimicrobial agent. Often we use Silvadene. And then see those patients in a couple of days to make sure that their burn is healthy, the person is eating and drinking, and that they're doing a good job of taking care of their wound. They have adequate pain medication, and they're able to meet whatever their goals are at home, and that their burn's not getting worse. Especially children, we've transitioned a lot of patients to outpatient management with early follow-up in our clinic, which keeps our hospital beds open. But the patients need to have adequate resources to be able to do this. So other issues in burn care, burn patients are always septic, meaning that they always have an ongoing inflammatory response with vasodilation and a low SVR. But they're not always infected, meaning that they don't have a systemic infection that requires IV antibiotics. And in fact, giving IV antibiotics early in a burn patient may induce antibiotic resistance and could often be the wrong thing to do. In our burn unit, Pseudomonas and staph species are very common pathogens. All right, so this kind of gets into what makes a burn unit. Well, I love our burn unit because it's really a whole team, and it takes the entire team and everybody functioning well to get the results that we get in our burn unit. And this is so incredibly important, no matter where you're practicing burn care, to adopt the team-based approach. And there's so many people that are component in that, but I'll say the most important ones, in addition to the surgeon, are the nurses. And a lot of the burn care comes on the back of the nurses. They're doing the patient wound management, they're assessing for pain control, they're making sure the patient is eating and drinking, they help the patients get up and walk and go to the bathroom and move around. So the nursing care in your burn unit will make or break your patient outcomes. And if you want to have the most high impact intervention, helping patients with burn injury. It is teaching your nurses and dialing into your nurses and how well they help take care of your burn patients. Our nurses are way more important than what I do in our burn care. In addition, you need a nutritionist and pharmacist. Burn patients can have altered pharmacokinetics, and I already mentioned the importance of nutritional delivery. Even if you don't have a nutrition, you really need to be paying attention to how many calories are being delivered to your burn patients. And then the other most important people, so between your burn surgeon, your nurses, your nutritionist, are your therapist. And sometimes your burn nurses may need to double as physical or occupational therapist. Or your doctors may need to double as physical or occupational therapist. In fact, anytime I see a patient that's getting wound care, I always go in and start stretching that patient and making sure that they have good range of motion. Why? Because if you have a patient who has open burn wounds and they're immobilized in a non-functional position, let's say with your elbow at 90 degrees, well, they're going to get tight with their elbow at 90 degrees, and then they're going to have a really hard time straightening out that contracture. So having therapists who are watching patients during the healing process and making sure that they maintain functional length of different areas of their body that are prone to contracture is incredibly important, and also a very high yield intervention to help with the burn care outcomes where you are. Additional components of burn care: a psychologist. Burn patients have substance abuse disorders, depression, and post-traumatic stress disorder. Social workers can help with community reintegration, and then of course emergency services help provide essential burn care before those patients come to your hospital. There's about 140 burn units here in North America. We have the American Burn Association, of which I'm a member, and I also help verify burn units to make sure that they're up to the standards of the American Burn Association. There's a number of referral criteria about who should come to a burn injury, and it's pretty straightforward. So do you have big burns greater than 10% total body surface area? Do you have deep burns, third-degree burns? Do you have burns to hard places like your hands or your feet or your perineum? Do you have weird burns like electrical injuries or chemical injuries or inhalation injuries? Do you have burns on sick patients, so people with pre-existing medical conditions, or complex burns in that patients with burn injuries, but they also have other trauma? Additionally, pediatric burns. So these are kind of criteria that would recommend patients to our burn unit. Overall, most patients recover and do well after burn injuries, but it requires the whole team, and it requires a lot of dedication from the team, a lot of resources, and a lot of buy-in by the patients. But there are good outcomes after burn injuries. And so survival is not enough. We need to ensure good functional outcomes, which in part of that is early mobility, social reintegration, and then the access to reconstructive surgery, specifically with plastic surgeons. In the United States, most care is actually delivered by general surgeons. And so I'm the oddball of a plastic surgeon who does burn care in our country, but I like to think that I do it very well because I know what sorts of reconstruction a patient may need, and I'm able to anticipate those and adapt my acute management of burn injuries to prevent or treat early long-term functional problems. Early mobility, including physical and occupational therapy, I mentioned that. Most common complications are hypertrophic scars and keloids, and you can see this patient who has skin grafts of his neck and his chest, or specifically his neck, but he didn't have any skin grafts of his face, and he went on to have some delayed wound healing of his face, which led him to have hypertrophic scars and keloids, but the neck actually was improved. Other types of scar management: early wound closure, compression garments, silicone sheeting, and laser. I use a lot of carbon dioxide laser in the management of my burn patients. This essentially restarts a healing process in a much more organized way, leading to improved collagen alignment. and can take hypertrophic, immature scars and move them into flatter, more functional, better pigmented scars. And you can see some before and after pictures that have been published using fractional CO2 laser. This is a patient who had a chest burn contracture that I treated. So she came to me for breast reconstruction after a 30% burn when she was 5 years old. Here's what she looked like before any sorts of surgery. Here's the surgery that I did in terms of releasing her contracture, and you can just see how much skin she was missing secondary to her burn injury. She actually had all the volume of her breast present underneath her skin, but it wasn't sized or shaped like breast because of her contracture. I used negative pressure wound therapy, and this was a trick that I learned actually on a global health trip where they were using an aquarium pump as your negative pressure wound therapy. But this is a great way to bolster skin grafts down, is using negative pressure. And so this is what she looked like at 1 week, 2 weeks, and 3 weeks after my skin grafting surgery. And you can essentially see that she's got what appears to be breast, and she has cleavage, and she has an inframammary fold now, and before she had none of that. And this is her before and after the surgical treatment. And unfortunately, I lost this patient to follow-up. But I would have considered ongoing reconstruction in terms of her breasts. But this is just an example of what we can do as plastic surgeons in terms of restoring form and function, even in very, very old burn injuries. This is an example of a contracture release using Integra, which is a skin substitute. This patient didn't have a lot of autologous skin, so we used this to release his contracture and grafted him. This is a patient who had serial scar excision, and you can see this unsightly meshed skin graft scar on his arm, which over time, with about 3 surgeries, we can excise, and then now he has normal skin and just a linear a line going down his arm as opposed to this unsightly graft. Tissue expansions is another way of reconstructing patients, and this is a patient who has cicatricial alopecia of his scalp. You can take about 30% of the scalp and expand it up to cover the full scalp over multiple surgeries, and essentially what you do is make an incision, place a balloon underneath the hair-bearing scalp, blow up the balloon over time, and then use that scalp skin to reconstruct the skin that is missing the hair. And so you take the balloon out, now you got a bunch of extra tissue, and you just advance that over. And then a lot of cutting edge plastic surgery was developed out of burn care in the early World War I and World War II. But burn care continues to be very challenging, especially when you have very difficult burns, as this gentleman who was a fireman with a devastating burn to his face. And this led to the first face transplant, which is a full face transplant in a patient that had this horrible mask-like appearance after his burn reconstruction. And so the first full face transplant was actually done on a burn patient. In summary, burns are complex, they're variable, and they're interesting. I, as a plastic surgeon, find them incredibly challenging to treat, and it's my life's work and passion to help patients with burn injuries. Understanding your burn physiology facilitates your best patient outcomes, and most patients recover and restore their previous life. I want to say it's incredibly important as a surgeon to never lose sight of what our mission is. And I tell my residents every day in the burn unit, they're probably tired of hearing me say it by now, but it's important, is that I take care of people with burn injuries. I don't take care of burn injuries. And why is that important? Well, it's because different people have different goals in life. Different people have different injuries. They have different tolerances to pain. They have different resources and are able to understand different kinds of treatments and comply with different treatments. So if you treated every person the same with every burn injury, that would be doing a disservice to the person that you're taking care of, because these people really are different, and therefore they need individualized and different care. And so I'll leave you with that, and we'll go on and take some questions. And I want to just say thank you all for inviting me again to give you this talk, and I hope it was helpful.
Thank you so much, Dr. Justin Gillenwater, for that insightful presentation. I think I have a lot to think about, and I also imagine my fellow students as well. And I'm sure there are some questions and comments also to share. Personally, my biggest takeaway has been that patients deserve to have a multidisciplinary approach in order to take care of all their needs. And also it's important to look at the patient as a whole and also think about their particular needs and their psychological well-being as well. So to get us started, feel free to raise your hand, unmute your mic, or type in your question in the chat box. To kick things off, my question is that there are so many innovations in burn care, like you mentioned, the skin substitutes and many other things. And how feasible are these to implement in a low income setting? And how can we optimize the lives of our patients?
That's a great question. And I think it just depends on what your system is and how well you can integrate some of the other technologies. I'll say that I actually don't use any allograft in the care of my burn patients. So having the access to allograft, I don't think is a necessary care in burn, a necessary component of burn care. And to answer a question in the chat, cadaver skin does not revascularize like a regular graft, meaning that I can't take someone else's. I can't have a patient, because I have parents ask me this all the time if they have a child that's burned. I can't take the parent's skin, put it on the child, and heal that wound using only the parent skin. So allograft actually does not revascularize like a regular graft. Ultimately, patients with large burn injuries require autologous, meaning skin grafts that come from their own body. So the main uses for skin substitute that I see, and this is why I don't think skin substitutes will be that helpful in a resource limited environment, is that the best uses I get from skin substitutes are in patients with really large burn injuries, and I'm talking 80% to 90% total body surface area injuries. And what I use the skin substitutes for is I will remove the burn tissue and put skin substitutes on, and then stop and trick the body into thinking that I have temporarily closed that wound. The benefit I get from this is that those patients become less sick. But the problem is that they're still sick, they're still in an ICU, and you need to do a lot more surgery, as their donor site, basically say you have an 80% injury, you have at max 20% of your body you can use as donor site. So I'll need to reharvest that 20% over and over and over and over again. And the skin substitute is used to temporize the patient and keep them from getting sick until I can put autograft on them. And why I say skin substitutes are probably not going to be so important for improving your outcomes is that the better improvement, you would have a better outcomes if you improve your critical care and start focusing on the patients that are in the 20 to 40% total body surface area category by doing other improved wound care, nutritional delivery, critical care, vent management, and things like that. Because really, when I don't use a lot of skin substitutes in patients with less than 40% total body surface area. And that is usually the kind of patient that may die in a burn unit. A 40% or higher body surface area burn may die from their inflammatory response and burn shock without good critical care. I hope that answers answers your question. So my answer, I guess, would be don't worry so much about skin substitutes and their role in burn care right now. Much more important is the person in a critical care environment and focusing on people with medium large burn injuries like 20 to 40% and really trying to save those people and maximize their outcomes.
Thank you very much. That answers my question.
Let's see, Alice says, burn patients need extended follow-up. What are the existing policies that support them in terms of insurance and other costs? That's a great question, Alice, and really tough because in our country we have so many different kinds of insurance. So I can take care of patients in my burn unit, and then all of a sudden their insurance company says that they can't come back and see me in my burn unit, and they can't go to any burn units. They have to be seen by somebody else and outside the network. So, I try to get around those as often as possible by getting those patients back into our unit and advocating for those patients to come back and see specialist burn care doctors by getting their insurance companies to agree to it. But it's a real challenge. And so how often do you need to see people back? Certainly, I like to, if in the setting of anyone that I've operated on that I think is at risk for developing a contracture, I try to see those patients back for at least a year until I'm sure that they're out of the risk for having contractures. If you have small burn injuries and you know they're going to heal up just fine, probably don't need to see those patients. But if you identify people who are at risk for having functional impairments, sometimes, you'll need to see those patients back for up to a year. I've had patients that I've treated for my whole career that I treated for over 10 years when I first started practicing, and I'm still operating on them now. Well, it's been my pleasure talking with you all today. If you would like any sort of additional discussions or talk in burn care, Alice, please just reach out to me. Happy to address other components of burn care. We didn't really get too much into burn reconstruction, and that's a really fascinating topic from a plastic surgery perspective as well. So again, thank you all for your invitation today.